Good morning, everyone. My name is Kimos Godaitis. I'm a podiatrist and currently head of the R&D department at Fixtoe Company and Products. And first of all, I would like to thank Arbitas for inviting me to this event. It's a real pleasure to be here with all of you and continue collaborating and learning together because any opportunity to share knowledge among in my daily life, English is not the main language I use when talking about podiatric technical topics. So I apologize in advance if any term is not accurate, but I will try to do my best. As you can see, I'm not one of the most veteran podiatrists, but after years of learning alongside a great Spanish reference like Fran Monzo, I hope I've picked up some valuable insights. So today I'm going to try to share a few tips and clinical reflections I've learned from working close to him, especially related to the management of the metatarsalgia. I'm not here to present anything revolutionary that most of you don't already know, but I hope that some of these ideas may be useful, especially for younger colleagues who are starting their path in podiatry. As you know, metatarsalgia is one of the main reasons patients visit a podiatrist. Along with heel pain, these two conditions represent around 80% of all the cases that can be treated with orthopedic approaches in our daily clinical practice. Both pathologies can be managed using conservative and invasive strategies. In most cases, we start with the conservative ones, but the methods don't always give good results for every patient. This is mainly due to anatomical differences between individuals and the chronic nature of the lesion, which often influences both the treatment and the success. As you can see, there are multiple causes behind the metatarsalgia, and the most of them are related to mechanical alterations. Some of the most common are these: alterations in the metatarsal parabola, such as index minus, predislocation syndromes with MTP, metatarsophalangeal joint synovitis, calf muscle retractions, digital deformities, and the plantar flexion of the forefoot. These factors all contribute to increase the biomechanical stress in the metatarsal area, leading to pain and sometimes dysfunction. To make the differential diagnosis of metatarsal pain, we will focus on three things. This is the type of the pain, the hyperkeratosis pattern, and the clinical palpation tests. First, we need to check if the pain has a mechanical origin. Mechanical pain usually appears with morning stiffness, but it lasts less than 20 minutes. This is very important. And it gets worse with walking or activity and better with rest. This type of pain normally responds well to medication and conservative treatments. And it usually is unilateral, but affects only one joint. If the pain is bilateral, affects several joints, and the morning stiffness lasts more than 20 minutes, we must think about inflammatory pain like arthropathies. In these cases, anti-inflammatory drugs help, and orthopedic treatments may improve the symptoms, but the pain don't go away completely. Also, if the patient reports numbness, paresthesia, or cramps, we must consider vascular or neurological causes. So to make the good diagnosis, we must always analyze the type of pain, the skin lesions, and the information the patient gives us. These are the parts. We know that metatarsalgias can be classified based on the location and the type of the hyperkeratosis. The most common types are the second rocker and the third rocker metatarsalgias. The second rocker metatarsalgias, as we can see in this image, is a very clear hyperkeratosis lesion under the metatarsal heads. This lesion is well defined, does not extend to the front, and is centered just under the metatarsal heads. This pattern is usually seen in patients with calf muscles gastrocnemius retraction, plantar flexion of the Lisfranc joints, the fat pad arthropathy, or the rigid deformities in the metatarsophalangeal joints. It can also appear in people with arthropathies like claw toes or a consequence of foot surgery. As you can see in this image, the third rocker hyperkeratosis is more diffuse and wide than the second rocker. It usually affects several metatarsals, and the lesion appears under the metatarsal head, but extends to the front area, this part of here. This is the main difference compared to the second rocker lesions. We normally see this type of dermal patterns in patients with an alteration of the metatarsal parabola, like the index minus, or instability of the first ray due to low dorsiflexion stiffness. This is what we used to call the first ray hypermobility. This kind of instability causes the load during the second and the third rocker phase to the transfer to the second metatarsal. We also find this pattern in patients with the first MTP joint problems like allus rigidus or allus abductus valgus. Continuing with the physical examination, we are going to talk about the palpation. The palpation is a very important part of the clinical exam when we want to make a differential diagnosis. When a patient comes to the clinic with foot pain, it's important to have a list of possible causes in mind. During the examination, we look for specific signs that help us to confirm the rule or rule out these possibilities. For example, when we palpate the metatarsal head or the diaphysis on the dorsal side, it's very common to find pain in patients with bone edema. This kind of pain usually means there is a bone stress reaction, and we must consider it as a possible cause. It is very important not to ignore the concept of bone stress. Anamnesis is key because even without imaging test, we can estimate the level of bone stress in our patient. We need to determine if we are dealing with, first, the bone stress fracture, where the pain appears even at rest and causes a functional limitation, or it's just a bone stress reaction, which is a phase of bone adaptation to repeated loading cycles. But how can we identify this without tests? If the patient tells that the pain increases with activity and improves with rest, and that is not limit his daily function, we are on the early side of the stress line. In these cases, full rest is not necessary. So what we need to do is to adapt the load and apply orthopedic treatments to reduce the pressure in the metatarsal area. But if the patient says that the pain appears at rest and lasts for days after the activity and causes a functional limitation, that we must expect a stress fracture. In that case, the treatment should be more restrictive and load must be reduced significantly. Fran always says that anamnesis gives us 80% of the information we need to understand what is happening with the patient. But today we seem to be losing this essential part of the traditional clinical medicine, talking to the patient and really listening. Because many times the patient is not only telling you what hurts, they are also giving us the key of the solution. Now, regarding palpation, it's very useful to palpate the intermetatarsal space here. This helps us to make a differential diagnosis between the nerve and treatment, like the Morton's neuroma, and the intermetatarsal bursitis. Other clinical tests, like the Mulder test, help us to evaluate if there is a nerve compression, which is often related to the Morton's neuroma. However, a negative Mulder test does not rule out the presence of the neuroma. If we still have clinical suspicion, the next step is to confirm with an ultrasound scan. The Lachman test is another useful tool. We can use it to assess the stability of the MTP joint, although it can actually be used in any joint to evaluate how stable it is. When we perform this test, we are checking the joint separation during dorsal flexion. This movement depends on the passive stiffness of the joint, not to control from the central nervous system. It's important that if the Lachman test is positive, we should suspect that the metatarsal pain may be related to a rupture or injury of the plantar plate. The plantar flexion or the MTP joint help us to detect possible synovitis or capsulitis and also check if the plantar plate is affected. This is because one of the indirect signs of synovitis appears during this movement. When we perform the plantar flexion of the MTP joint, we create tensile stress. This stretches the dorsal capsule. If the capsule is inflamed, as in synovitis, the movement will cause pain. The Gilligan test gives us information about the flexibility and the degree of reduction of the digital deformities. To perform it, we apply pressure with our finger on the metatarsal head in a dorsal direction while checking if there is plantar flexion at the MTP joint. This movement is usually produced by the tension on the flexor plate and surrounding ligaments. If the toe drop and the level of the other toes, it means that the MTP joint is soft tissues are working well. But if the toe stays elevated and it does not come down, we can suspect a failure on lesions in the flexor plate. It's also interesting to assess metatarsal mobility to make a differential diagnosis. In the left image, on the second toe, if the patient has no surgical history, we can suspect of a Freiberg's disease. It's like the allus rigidus, more or less, but in the second MTP joint. We can also assess the first ray to check its dorsiflexion stiffness. As I mentioned earlier, a first ray with low stiffness during dorsiflexion, also called the first ray hypermobility, is related to metatarsal pain in the second and third ray due to this load transfer. This is very important when we're planning our orthopedical treatment because the insole design must not only reduce pressure on the metatarsal heads, but also help create a first ray with good stiffness. This stiffness allows us to resist the ground reaction forces, to support the body weight, and to reduce overload to the other metatarsals. Also, we can use the Hintermann test to check for the dorsal deformities on the first metatarsal. Here. The most well-known is the metatarsal primus elevatus. In these cases, it's important to include an extension under the first ray, like the Morton's extension, as part of our orthopedical treatment. In my opinion, about 80% of the painful metatarsal conditions, especially those related to the third rocker, where the pain is felt in the anterior area of the metatarsal head, this part of here, are actually lesions on the plantar plate. Sometimes the patient has pain in this area, but the clinical tests come back negative. However, a negative test doesn't mean there is no plantar plate rupture. In many cases, there is a pericapsular fibrosis caused by the overload, which appears before the actual rupture of the flexor plate. As you know, there are different stages and clinical presentations of the flexor plate problems. As shown in this image, in the earlier stages, we usually see deformities in the sagittal plane. But in more chronic cases, the deformities appear often in the transverse plane. If you look at this image on the left, you will see that the flexor plate is a structure about 2 to 4 millimeters thick. Because of its anatomical position, it does not only transmit tension, but it also works like a spring ligament, similar to the acetabular pedis. Its function is to hold the metatarsal head and adapt to the plantar convexity. So it's exposed to also to compressive forces. This means the flexor plate doesn't just suffer from tensile stress caused by the fascial tension, but also from important compressive stress, which can reduce its thickness and make it very vulnerable structure. What is the biomechanical role of the plantar plate? Well, the plantar fascia is closely connected to the flexor plate. which continues towards the proximal phalanx here. Because of its relationship, we can say that the flexor plate is the main stabilizer of the metatarsophalangeal joint, keeping the toe in contact with the ground. It works in a passive way, meaning it's not controlled by the central nervous system. During the gait cycle, as we move the center of mass forward, the ground reaction forces increases in this part of here in the forefoot. This happens in the second rocker phase and leads to a situation where the foot tends to flatten. So the more tension there is in the plantar fascia during the second rocker, the more stable the toe remains to the ground. In the third rocker phase, the flexor plate is exposed to the high tensile forces, as you can see here, this sign. These forces come from three main sources. The first is the gastrocnemius, the gastrosoleus complex, pulling from behind. The second is the plantar fascia under tension. And the third one is the dorsiflexion of the MTP joint, caused by ground reaction forces. All this creates a peak of mechanical stress on the flexor plate during this phase of the gait. In this ultrasound image, courtesy of Javier Alcalá, we can clearly see the connection between the metatarsal head and the flexor plate. The flexor plate, here, this part, inserts at the base of the proximal phalanx, allowing it to generate the plantar flexion forces to contribute the toe stabilizing during the gait phase. What factors are associated with plate injury? Well, as we all know, it's multifactorial. We need to understand that any situation that increases tensile stress on the plantar fascia can be a triggering factor. Over time, this stress can damage the fibrocartilage, leading to the plastic deformation or even a partial rupture. Some common examples are the excess of the body weight, the medial deviation of the subtalar joint axis, or post-surgical changes, especially when the second toe is elevated. And don't forget patients who wear high heels regularly, because they create constant overload in the forefoot. For a morphological and mechanical point of view, there are two main factors that are often related to the plantar plate injuries, both in clinical experience and in the scientific literature. The first one is the presence of the index minus, and the second one is a first ray with low dorsiflexion stiffness, also known as first ray hypermobility. These two factors increase the load on the second and third metatarsals, which can lead to progressive damage of the plantar plate. When the fibrocartilage is exposed to much tensile and compressive stress over time, the structure becomes weaker and thinner, and even the rupture occurs here. This rupture can be acute, caused by a strong dorsal flexion from trauma, or chronic due to progressive overload. But what happens next? The muscles controlled by the central nervous system, like the toe flexors, are still active, but now they don't have their passive opponent, which was the flexor plate. As a result, the unbalanced contraction of these muscles during the gait cycle leads to the digital deformities such as claw toes or hammer toes. Here we have more images where we can see the partial rupture of the flexor plate in this ultrasound image. As a result, here is a floating toe, this one, showing a deformity and the presence of a dorsal heloma. This alloma is already a sign that the joint is becoming rigid. The main symptoms of the press dislocation syndrome, the MTP synovitis, and floating toe includes pain in the anterior area of the metatarsal head, irritation and increased joint fluid, and visually the toe no longer touches the ground. These are key signals that indicate a possible alteration of the MTP joint and at the plantar plate. The causes of the plantar plate problems are multiple. They can include traumatic injuries, inflammatory arthropathies, mechanical overload, or the presence of a floating toe after surgical procedures. We often see this in this kind of complications after performing the whale type surgeries. Patients with plantar plate pathology often show symptoms similar to neuropathic pain. They may report paresthesia, numbness, or radiating pain in the forefoot. In these cases, we must consider a differential diagnosis with the Morton's neuroma. However, both the pain location and the clinical findings may indicate that the inflammation around the MTP joint is compressing the interdigital nerves, which could explain the neuropathic sensation. This pathology can be classified into 4 main stages, but depending on the criteria used, we can find different classification tables. If we combine all the subclassifications, we can group the condition into 5 stages: 0, 1, 2, 3, and 4. Stages 0, 1, and 2 are usually good candidates for conservative treatment. Stages 3 and 4 may require surgical treatment if we want to correct the deformity. However, if the goal is to reduce pain, conservative treatment can be applied at any stages, though the prognosis and success rate vary depending on the severity. What the scientific literature clearly shows is that the earlier the diagnosis and the more we manage to keep the toe in plantar flexion using taping techniques or orthopedic device like the Fixtoe, the better the prognosis and the slower the progression of the deformity. What clinical tests can we perform to this? First of all, the pain should be located in the anterior area of the metatarsal head. Then the Lachman test must be performed, and if it's positive and shows more than 2 millimeters of joint separation, this also can be confirmed by X-rays. Next will be the Kalikian test, which gives us information about the degree of reduction or flexibility of the toe. It's important to note that if we have a fully positive Kalikian test, I mean the toe doesn't go down or even move towards the plane of the other toes, the prognosis for conservative treatment is poor. But if the toe moves down, even partially, and we can see plantar flexion movement, the Fixtoe or the taping techniques are well indicated. We also use the MTP plantar flexion test to see if this movement produces pain. If the test is negative with no pain, and the Kalikian test shows some flexibility, we can apply stronger plantar flexion forces with the Fixtoe device. However, if the test is painful and the patient has functional limitation, we should apply retraction more carefully and gradually with our device or with the taping techniques. Finally, the last stress test is to separate the MTP joint and see if the pain appears. There is also a digital grip test under load, where we place a small piece of paper under the big toe and we ask the patient to do plantar flexion to check if it's difficult to pull the paper out. If it is difficult, this means that the toe has a good gripping ability. It can hold contact with the ground. What can we do? We have some traditional conservative treatments such as tight taping and horseshoe offloading. With tight taping, we use the tape to lower the toe and bring it closer to the plane of the adjacent toes in the same level. This helps to reduce the tension and the flexor plate during gait cycle. The main function of the taping is to prevent excessive dorsal flexion of the toe during the propulsive phase and to avoid overstretching the plate. In the swing phase, the extensor muscles contract and cause dorsal flexion. If the plate is already damaged, this movement can increase the tension and produce pain. As you can imagine, the horseshoe of loading, along with almond pads or metatarsal bars, are used to reduce compressive stress under the metatarsal heads in the center. Today, we have alternatives to the traditional taping that offer several advantages, such as the better hygiene, more comfort, the possibility to reuse the treatment, and fewer skin problems like allergies or irritation caused by the latex in the tape. One of these alternatives is the Fixtoe device. The straps of the Fixtoe device are placed over the toe and anchored to the sole, and they behave like the adhesive tape. They apply plantar flexion forces on the MTP joint, helping to align the toe. This way, the force produced by the toe flexors during the gait is neutralized, and this prevents the progression of deformities such as cloud toe or the hammer toe. On the other hand, it's not only important to lower the toe, it's also essential to cushion the impact during walking. In this sense, the metatarsal pad included in the Fixtoe device helps to reduce the compressive forces generated by ground reaction in the metatarsal area. This extra cushioning supports pain relief and improves pressure distributing during the gait. The question is, in which cases of metatarsalgia associated with plate injury is the Fixtoe device indicated? Well, the Fixtoe device is mainly indicated in the first 3 stages of the plantar plate pathology. In stage 0, where we have a negative Lachman test, a decreased plantar grip strength, and pain but no visible digital deformity, this is considered really a pre-stage, and early intervention here is the key. In stage 1, we see the minimal deformity, joint widening due to this synovitis, pain and reduced grip, and a positive Lachman test with dorsal subluxation of the MTP joint less than 50%. In stage 2, the deformity is moderate. The Lachman test is clearly positive, and there's a greater loss of grip strength. In all these stages, we recommend using the Fixtoe device, especially during the acute pain period, while we are also designing the patient's orthopedic insole. The 2 treatments, Fixtoe and insoles, work together to reduce symptoms and improve the function. So we use the Fixtoe device when we have a positive Lachman test, a flexible or semi-flexible Kellikian test, and a flexible digital deformity. These are the key clinical signs that indicate the Fixtoe is appropriate to support the toe, reduce pain, and prevent further deformities. On the other hand, in which cases you should not place the Fixtoe device? Basically, the Fixtoe device is less indicated in more several deformities. The more rigid the MTP joint is during the plantar flexion, the less effective the device will be. In other words, in cases with fixed and advanced deformities, the prognosis and success rate of using the Fixtoe are clearly lower than expected. The Fixtoe device should not be used when we have a positive Lachman test, rigid Kellikian test, and a fixed digital deformity. Also, if the patient has pain in the anterior metatarsal area, but the Lachman test is negative and grip strength is normal, there is no clear sign of a plantar plate lesion. In this case, using Fixtoe will be inappropriate. because it could stimulate a functional allus limitus. This happens because the strong plantar flexion force applied to the phalanx can increase compressive stress on the metatarsal head potential, worsening the pain. The Fixtoe device is also indicated as a post-surgical stabilizer, especially after the metatarsal surgeries, to help prevent the appearance of the floating toes during the recovery. The binomial of the plantar orthosis and Fixtoe and the Fixtoe device. In our opinion, and this is still our clinical hypothesis, the Fixtoe device or traditional taping is most effective when the main force involved in the plantar plate injury is tensile stress. In other words, in the early stages, when the pain is mainly caused by excessive tension on the plate, the Fixtoe device works very, very well. This is what happens to prevent the deformity from progressing. Most studies agree that the earlier we apply the treatment, the more we can slow down the progression of the deformity. However, when we are dealing with rigid deformities, where the main force is compressive stress from the ground, we should focus on orthopedic treatments using metatarsal, horseshoes, and retrocapital pads. One important factor we often see in these patients is instability of the medial arc. So our treatment must also aim to control pronation using strong arc supports and medial flanges to limit that movement. This type of correction increases the stability of the first metatarsal, helping it to better resist ground reaction forces and prevent the load transfer to the second metatarsal head. One last key point is the correct placement of the retrocapital pad, because many patients complain that the insole feels uncomfortable. This usually happens because the pad is placed too forward. When they wear the insoles inside the shoe and they feel and the foot slides forward, the pad ends up under the metatarsal head, increasing discomfort. That's why we must always check that the pad is truly retrocapital once the insole is in the shoe and not under the heads. We should not use the Fixtoe device in patients with dermatological conditions or in those with diabetic foot. In these cases, the risk related to the friction, pressure, and reduced sensitivity makes it unsafe. It's important to prioritize skin integrity and protection in these patients to avoid complications in the future. Now we are coming to the end, and for those who are more curious, here is some of the scientific literature that supports that what we have discussed. There is a study conducted by the professor Angel Orejana and part of his research team, where we found that the Fixtoe Pro device reduces maximum pressure under the second metatarsal head by 36% compared to traditional taping. We also observed a reduction of 4 to 6 points on the VAS pain scale. And recent studies confirm that the early conservative treatment can significantly delay the progression of the deformity, which highlights the importance of acting early and selecting the risk tools for each stage. Having said that, I really hope you enjoyed the session. I've tried to bring something useful for your daily practice, and I hope you've been able to pick up at least few tips or ideas that you didn't know before. Thank you very much for your attention.